Om Swastiastu, Doctor and colleague. We are from Sgd B1, and today we will present our student project entitled Brain Herniation. This is our outline. Here are our group members. Thank you for the opportunity. My name is Geg Mas Anantalakshmi with the last digit of NIM number 001. Today, I will go over Chapter 1. The first one is background. The cranial cavity contains constant amount of brain, blood, and CSF. Cerebral herniation happens when one element rises and the other decreases, causing the brain areas to shift. Symptoms may point to an underlying illness, but they may be vague. To diagnose a patient, a complete medical history and clinical presentation are needed. Healthcare providers should be aware of herniation type overlap and other related issues. Misdiagnosis can cause high patient morbidity and death. Here are the problem formulation. Objective, and the benefit of our student project. The next topic will be explained by my colleague.
Hello, my name is Marta and my last digit of student number is 064. Now I'll talk about the definition of brain herniation. Brain herniation is a life-threatening condition where there is a shift in brain tissue from its normal location to the surrounding space. Brain herniation usually occurs when intracranial pressure increases so that the brain is pushed to the side or downward through a small normal hole in the relatively stiff tissue which functions to divide the brain into several parts. Brain herniation can be caused by other problems suffered by the patient, such as brain edema, bleeding, tumors, liver failure, and kidney failure. Symptoms that generally occur include headache, nausea, vomiting, changes in mental status, and causing triad. Sulfalcine, transtentorial, and tonsil herniation are the most commonly recognized forms, and each type has its own specific characteristics and potential complications. That's all for me. Thank you.
Good morning. My name is David Chandra with the NIM 066. Today, we'll have to explain about the etiologies of brain herniation. One of the etiology is hematoma, blood accumulation in human's brain that causes compression to the brain tissue. There are four types of hematoma that can occur, which are epidural hematomas, subdural hematomas, subarachnoid hematomas, and intracerebral hematomas. Brain cells will be stressed and not work normally. It also blocks blood vessels around the brain area, which causes hypoxia. Another etiology is the tumor cells, which can press on surrounding tissue, causing brain swelling. It is caused by malignant infarction and associated with a cerebrovascular disease, causing stroke or blocked blood vessels in the brain. Swelling tissue can increase intracranial pressure. CSF accumulation is also the etiology of brain hernias, which is hydrocephalus, causes CSF to stop flowing properly in the brain. It leads to increased intracranial pressure, and brain infections can also increase intracranial pressure due to accumulated inflammation and the pus. Another etiology of a brain herniation is metabolic hepatic encephalopathy, a condition related to liver disorders such as liver cirrhosis. Toxins can accumulate in blood and affect the brain, causing behavioral changes and increased intracranial pressure. That's all from me. Thank you.
Hello everyone, my name is Natania Sutedja with the last digit of student number 175. I'm gonna explain about characteristic of brain herniation. Brain herniation is neurological emergency that is associated with poor outcome. The clinical manifestations are not specific and can be include headache, nausea, and vomiting. Furthermore, patient can show signs of somnolence and obturation with agitation that can increase by time. However, it is difficult to identify whether patient's mental status worsens because of the increasing intracranial pressure or other causes like infections, uremia, polypharmacy, and other causes. Cerebral herniation is mostly caused by intracranial pressure that develop following lumbar puncture. The most common risk factor of brain herniation is increased intracranial pressure. Brain herniation that is treated by continuous lumbar drainage with early identification is mostly reversible, but the common risk factor associated with lumbar drainage include CSF, overdrainage, and can lead to nausea, headache, and vomiting in alert patients. That's all from me. Thank you very much.
Hi, my name is Caitlin and I'm going to continue the type of hernia. As the name has said, this transsensorial ankle herniation affects the ankle or deepest part of temporal lobe. It compresses the oculomotor nerve that causes the dilatation of the ipsilateral pupil, where the pupil will face down and out. Meanwhile, this descending type of hernia, or descending transsensorial herniation, is the second most frequent kind of brain hernia, where it puts the midbrain, posterior cerebral artery, and third cranial nerve under strain. And DTH is split again into two categories based on the position. First one is the central hernia, and the second one is the lateral, and it's split again into anterior and posterior hernias. Next on the ascending transtentorial herniation type, we have a mass effect pushing upward from the posterior cerebral fossa, then pushes the cerebellar pharynx and hemisphere superiorly through the tentorial incisura. This hernia, or cerebellar tonsillar herniation, have the most poor prognosis because the elevated pressure within the posterior fossa region induces the displacement of the cerebellar tonsils through the foramen magnum. This occurrence exerts compression upon the upper cervical cord and lower brainstem, thereby posing a grave threat to life. Last but not least, we have transclavicular herniation, or often known as extracranial hernia, the protrusion of brain matter through a cranial defect that has been induced by either trauma or surgical intervention could cause this hernia.
Hello everyone, my name is Erick Gonata with 3 digit of my student ID is 096. So today I will continue my colleague presentation. In this subchapter, we will be discuss about the pathogenesis and the pathophysiology of brain herniation. As we all know, there are some type of herniation. Firstly, we will talk about the escalation of ICP towards brain herniation. So talking about the escalation of ICP, talking about ICP itself, as we know that the pressure detected inside the cerebral vault is known as intracranial pressure or ICP. So this pressure is dynamic, made up of systolic, diastolic, and derived mean pressure, and it is subject to psychological fluctuations. The ICP itself is important to determine cerebral perfusion pressure or CPP. Monroe-Kelly doctrine suggests that the mean CCP equals to mean arterial pressure of or MAP minus mean ICP. As of it, the sum of blood volumes in the brain, intracranial blood, and CSF is constant. Therefore, an increase in one of the determinant will result in decrease of the other determinant. Um, Brain tissue itself will be moved from one compartment into another if the intracranial volume change more than this compensatory system can handle. So, if we talk about the intracranial volume, if the volume exceeded more than our body can handle or our body can compensate, the brain tissue will be moved from one compartment into another. It could be through the acquired or anatomical gaps. All right. The second type of herniation is the subfalcine herniation. This type of herniation itself is the most common one. It is also known as the midline shift or cingulate hernia. It is characterized by a midline shift of the medial brain regions brought on by a mass effect in the contralateral cerebral hemisphere. Most notably movement of the contralateral cingulate gyrus below the falx cerebri, as we can see in the uh, picture. Alright, move on to the next type of herniation. We got transolar or transsphenoidal herniation. This type of herniation is the less common one because it is usually associated with subfalcine and transtentorial hernias, which will be present in the next slide. The inferior frontal gyrus is shifted posteriorly and caudally with regard to the sphenoid wing, which cause ascending herniation to happen. The displacement of the anterior temporal lobe anteriorly in the cranial direction across the sphenoid ridge result in ascending herniation. Ipsilateral anterior circulation stroke is caused by the displacement and compression of the middle cerebral artery or MCA. and supraclinoid internal carotid artery against the anterior clinoid process. The presentation will be continued by my colleague.
Hello, my name is Gusti Saraswati. My last register number 056. Now I will explain about diagnosis. Brown diagnosis is essential to diagnose brain herniation. CT scan or MRI can be asked to determine condition inside the head. The history and clinical information of brain herniation patient is very important for planning, assessing and providing appropriate treatment to the patient. Some important information for anamnesis and clinical evaluation of brain herniation patient is a history of symptoms experienced by the patient, such as severe headaches, vomiting, visual disturbance, muscle weakness, or change in behavior. Medical history is also important to diagnose brain herniation, such as family history of neurological or genetic problems, history of chronic disease, history of head injury, and physical examination need to be carried out to determine neurological sign. That's all for me. Thank you.
Hello, doctor and friends. My name is Geraldine Rachel with the last three digits of student ID 100, and I'm going to elaborate the complications of brain herniation. So the compression to the vital brain structures and blockage of the blood flow can lead to impaired neurological function or even brain death. Typical symptoms of the complication include altered consciousness, pupillary abnormalities, and motor impairment. The rapid medical intervention in this case is required to relieve the pressure and prevent further harm, such as death resulting from respiratory arrest. Typically, it is involving surgical management or medication administration to lower the intracranial pressure. That's all from me. Thank you.
Next, I will explain about the prognosis of brain herniation. But before that, let me introduce myself. My name is Putu Indriati with last digit number 231. The prognosis of brain herniation is a multifaceted aspect influenced by numerous interconnected factors, each playing a pivotal role in shaping the overall clinical outlook. For example, is duration of herniation onset, patient age, the initial Glasgow scale, score open presentation, the presence of anisocoria, associated polytrauma, concurrent episode of hypoxia, and hypotension.
Greetings, my name is Gayatri Karuniaputri with Trila students number 235. In this occasion, I would like to tell you more about management of brain herniation. Brain herniation, often called as brain cut, are labeled as medical emergency and life-threatening neurologic emergencies, which when the cases came, patient safety is the primary concern. In brain herniation, we can divide the management into four types. The first one is initial treatment. When the cases came where brain injury as the causes, we needed to prioritize in airway, breathing, and circulation, and also positioning the head of patient to be raised to above 30 degrees and correcting any abnormalities found. The second one is admission to an ICU for directing the patient whether the patient needed some supportive treatment for reducing the ICP patients. Next is brain imaging or CT scan. Normally, the CT scan are the basic supporting diagnosis that available for determining the cause. And the last is for the investigation to help patient's condition. This could be giving the patient drugs or cerebrospinal fluid as F drainage, DC, hyperventilation, and others. That's it from me. Further information about management will be delivered by my friends. Thank you.
Hello, my name is Sabrina, and I will continue the explanation. It's about management. So there are more management that can treat the patient with brain herniation. The first one is initial treatment. Initial pharmacological management of elevated intracranial pressure includes pain and agitation interventions as well as the use of osmotic diuretics and hypertonic saline or HRT. And the second management is medications for intracranial pressure. The first one is fentanyl and remifentanil are the two continuous intravenous medication most commonly used to treat pain and therefore for intracranial pressure. Intracranial metabolism may also be reduced by the use of benzodiazepine. The third one is osmotic diuretics, specifically mannitol, have been widely used to control elevated of intracranial pressure. And the fourth one is osmotic agents are useful in reducing both intracranial pressure and cerebral edema. And if this management can treat the patient with brain herniation, The next step is surgery. Thank you.
Hello, my name is Pande Putu Candra with my last digit number R240, and now I'll present you about the topic 2.8 prevention. So, the prevention of brain herniation is crucial to avoid severe brain damage or death. Here are some ways to prevent brain herniation. First, early diagnosis and treatment of conditions that can cause increased intracranial pressure. Second, management of increased intracranial pressure involves the maintenance of an adequate cerebral perfusion pressure, prevention of intracranial hypertension, and optimization of oxygen delivery. And the third is the decompressive craniotomy, and the last one is partial or total resection of temporal lobe. Thank you.
Hello, my name is Zephania Ekklesia, and the last three digits of my student ID number being 127. To conclude, brain herniation is an emergency condition when brain tissue shifts from its place. Hematoma and tumor are the most common etiologies of brain herniation. The clinical manifestations of brain herniation are unspecific, which are headache, nausea, and vomiting. Cranial imagings, such as CT scan and MRI, are important to make brain herniation diagnosis. Complications of brain herniation include unconsciousness, pupillary abnormalities, motor impairment, and respiratory arrest. Patients should be stabilized first, then undergo surgical treatments. That's all for our presentation. Thank you for paying attention. I close the presentation with Paramasanti. Om Santi 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 Om.